Now we are going to start the neck. Now see this picture and tell me what is the diagnosis. So here you can see that the tumor is arising from medial side of carotid bulb. Clear? You can see the swelling. So here is the location of tumor. So it is arising from medial side of carotid bulb and this is known as carotid body tumor. So we are going to discuss the carotid body tumor. Okay, what are the other names of carotid body tumor? It is also known as chemodectoma. It is also known as non-chromaffin paraganglioma. Chemodectoma, non-chromaffin paraganglioma. So exact site of origin is, it is going to arise from chemoreceptor cells from the medial side of carotid bulb. So see the names. It is also known as chemodectoma, also known as non-chromaffin paraganglioma, clear? And it arises from chemoreceptor cells. So what is the origin? Arises from chemoreceptor cells. Okay, and where exactly? On the medial side of carotid bulb. So chemoreceptor cells located on the medial side of carotid bulb. Okay, see, this tumor is benign or malignant. So this is benign, unifocal and non-hereditary condition. So this is a benign tumor. It is unifocal and non-hereditary condition. Okay, 10% patients are having positive family history, but it is non-hereditary. Now see, in exams there is one question which is frequently asked, that what is the classification system, name of classification used for carotid body tumor, and the name of classification is Chamblin classification. We use Chamblin classification for carotid body tumor. Clear? 10% people have positive family history, and you will see that this carotid body tumor, it's having higher incidence in the people who are staying in hilly areas or people who are staying at high altitude. So these people who are staying at high altitude, they are prone to chronic hypoxia, and because of this chronic hypoxia there is carotid body hyperplasia. Okay, so another important point, that in this case 10% people have positive family history, 10% patients, positive family history, and there is higher incidence in the people who are staying at high altitude. Now see the clinical features. This is painless, slowly enlarging swelling. What? Painless, slowly enlarging, because it's benign. Now see, it is firm, rubbery. Since it's a vascular swelling, the location is at carotid bifurcation. It's a vascular swelling, that's why it is pulsatile. It is compressible, and if you put stethoscope over the swelling, what you can hear? Audible bruit. So what are the special features of this swelling? It is painless, slow growing or slowly enlarging. So painless, slowly enlarging because it's benign. Okay, it's firm and rubbery. Clear? Okay, since it's vascular swelling, it's a vascular swelling, so it's pulsatile, it's compressible, and there is audible bruit. It's compressible and there is audible bruit. Clear? Now see, if we try to move the swelling, see, its swelling is mobile from side to side, so there is side to side mobility. Now if you see the location of this swelling, this is internal carotid and there is external carotid, and since swelling is located at the bifurcation, what is the problem? There is splaying of internal and external carotid. So what? This splaying of internal and external carotid is known as Lier sign. Very important point. This is a vascular swelling. So if it's a vascular swelling, FNAC and biopsy are contraindicated, because if you perform or if you try to perform, there is excessive bleeding which can lead to death. So here, what is the investigation of choice for diagnosis? It is angiography and specifically carotid angiography. Clear? So see, there is side to side mobility. How we are going to make the diagnosis? The investigation of choice for diagnosis is the carotid angiography. Clear? And what is contraindicated in vascular swellings? In vascular swellings, FNAC and biopsy is contraindicated. So here also FNAC and biopsy. Clear? These are contraindicated. So here you can see this is the tumor, and what you can notice, there is splaying of internal and external carotid, and the tumor leads to splaying. This is known as Lier sign. So on carotid angiography, there is Lier sign, that is splaying of internal and external carotid. Now see, carotid body tumor is usually seen in 5th decade. Okay, so imagine if a patient is elderly and patient is having carotid body tumor. In that case, you are going to operate or not? So in elderly, we are going to avoid surgery. Why? Because the tumor is benign and in majority of patients it is asymptomatic. Okay, so see the management. If there is an elderly patient, in elderly patients, surgery is usually avoided. Clear? So what? Surgery is avoided. Why? Because of risk of complications. Okay, so tumor is benign, having slow growth, generally asymptomatic, so we avoid surgery. But imagine if the patient is symptomatic or patient is young and we are planning for the surgery, and the size of tumor, it's more than 3 centimeter. So if size is more than 3 centimeter, in these patients we go for pre-operative embolization. So what should be done in such patients? Pre-operative embolization. Okay, now see, if the patient is having size of tumor more than 5 centimeter, so if size is more than 5 centimeter, in these cases we go for excision with carotid artery replacement. So in such cases we go for excision with carotid artery replacement. Okay, so this is how we manage the patients of carotid body tumor. Now the problem, if we go for surgery, what's the problem? There are complications of surgery. So see, what are the complications? There is injury of cranial nerve. Which cranial nerve is most commonly injured? It is the superior laryngeal nerve. So see the complications of surgery. Complications, first, cranial nerve injury. And the question is asked, which cranial nerve is most commonly injured? So it is the superior laryngeal nerve which is most commonly injured. There is first bite syndrome. What is first bite syndrome? There is pain at the time of initiation of mastication. So another complication, that's known as first bite syndrome. And what is this first bite syndrome? It is pain with initiation of mastication. Generally, this carotid body tumor is unilateral, but imagine if a patient is having bilateral carotid body tumor and we go for excision of bilateral tumor. In such patients, there is baroreceptor failure. And if there is baroreceptor failure, what's the problem? There is wide fluctuation of BP. So third problem, especially in the patients who are having bilateral carotid body tumor. Okay, in such patients, if we go for excision, because of excision there is baroreceptor failure. Okay, and there can be wide fluctuation of BP. Okay, so it can lead to wide blood pressure fluctuation. So these are the complications of surgery. That's why it's better to avoid surgery in elderly patients. Now tell me the diagnosis in this newborn baby. So here you can see that there is a swelling located in the posterior triangle of neck, and this is the classical presentation of cystic hygroma. Clear? So what is the diagnosis here? This is cystic hygroma. Okay, What is cystic hygroma? These are multiloculated cystic spaces lined by endothelial cells. So cystic hygroma, this is multiloculated. In this case, there are multiloculated cystic spaces, and these are lined by endothelial cells. Endothelial cells. Now in this case, what's the problem? There is sequestration of jugular lymph sacs from lymphatic system. So if there is sequestration of jugular lymph sacs from lymphatic system, in these lymph sacs, what happens? There is collection of lymph or clear fluid. And since there is secretion of this lymph over a period of time, so these swellings are slowly enlarging. What is the association? Cystic hygroma is associated with which condition? Turner syndrome. So what's the problem here? In this case, there is sequestration. What happens? There is sequestration of jugular lymph sacs, okay, from lymphatic system. Okay, so there is sequestration of jugular lymph sacs from lymphatic system, and because of that, what will happen? These cysts are filled with clear fluid, lymph or clear fluid. Okay, since there is clear fluid, whenever we are performing the transillumination, these swellings are brilliantly translucent, not transilluminant. Meningocele is brilliantly transilluminant. These swellings are brilliantly translucent. Okay, and second important point, that it is associated with Turner syndrome. Right now, see, related to the location of this tumor or location of this swelling, questions are asked. What is the most common location? It's the neck. In neck, which triangle? Posterior triangle. Apart from this posterior triangle, it is also located in axilla. It is located in mediastinum. You can find it in inguinal region as well as in retroperitoneum. So see the sites. What's the most common site of cystic hygroma? And it's the posterior triangle of neck. Posterior triangle of neck. Okay, what are the other sites to remember? There is a mnemonic, and mnemonic is Amir. Clear? Other sites, A means it is seen in axilla, it can be found in mediastinum, inguinal region, or you can find it in retroperitoneal region. So these are the other uncommon location. Now see, in 50% cases, cystic hygroma is present at birth. So imagine if it is present at birth, what is the problem? There is difficulty in labor, difficulty in childbirth, and in rest of the cases, it is going to be detected after birth or diagnosed after birth. Now the problem. Now see, in 50% cases, it is present at birth. So it is present at birth, and if it's present at birth, what's the problem? Yes, it causes difficulty in labor. Clear? So there is difficulty in labor. There is one good thing also, what? That in certain patients, spontaneous regression is seen. So it is associated with spontaneous regression. Now see the location. Location is in the neck, posterior triangle of neck. So what is the problem or what is the danger? It can compress the airway. Second, sometimes there is infection and hemorrhage inside the cyst. Okay. So what are the clinical features? It's a cystic mass, and this cystic mass is located in the neck. So it can cause airway obstruction. This is one problem. Second problem, in the cyst, there can be infection and hemorrhage. Okay. See, this is a soft compressible swelling, and whenever child is going to cry, coughs, what happens? There is increase in the size of swelling. And what kind of swelling is this? This is brilliantly translucent. So this is soft and compressible swelling. size increases when the child is going to cry or child coughs, and this is the question which is asked. It is brilliantly translucent. It's brilliantly translucent swelling. Now see, for soft tissue hamartomatous malformations, soft tissue hamartomatous malformations, what is the investigation of choice? And the investigation of choice is MRI. And that's why for cystic hygroma, lymphangioma, lymphovenous malformations, MRI is investigation of choice. Okay, so see, for soft tissue hamartomatous malformations, investigation of choice is MRI. So MRI is the investigation of choice for soft tissue hamartomatous malformations. Okay, so it includes hamartomatous malformations. Clear? So it includes one, cystic hygroma, lymphangioma, cystic hygroma, lymphangioma, and lymphovenous malformations. Clear? So in these cases, what is the investigation of choice? MRI. We discussed that in certain cases there is spontaneous regression, but in majority of cases what we have to go for? We have to go for surgical excision, and we can use sclerotherapy also. So see the treatment options. The preferred treatment is complete surgical excision. So what's the preferred treatment? It's the complete surgical excision. Clear? We can use injection sclerotherapy also. So what are the agents we are using? We can use bleomycin, we can use OK432. It is also known as picibanil, which is derived from strep pyogens. Okay, so the alternative treatment is injection sclerotherapy, and these agents are asked that in cystic hygroma, what are the sclerotherapy agents we use? So you have to remember bleomycin and OK432. It is derived from strep pyogens, and the other name of OK432 is picibanil. It is derived from strep pyogens. So this is how we treat the cystic hygroma. Now we are going to discuss branchial cleft remnants. Okay, and these branchial cleft remnants typically presents as lateral neck masses in toddlers. So branchial cleft remnants. Okay, so all branchial cleft remnants are present at birth. So two important points. What is the presentation? Typically presents as lateral neck masses in toddlers. Clear? And all branchial cleft remnants, so all branchial cleft remnants are present at birth. Okay, so it includes sinus, fistula, cartilaginous cyst. Question was asked in AIIMS that cysts are more common in infants or older children. So see, cysts are more common in older children, and sinus, fistula, cartilaginous rest, these are more common in infants. Okay, so important points related to branchial cleft remnants: sinus, fistula, and cartilaginous rest. Okay, these are more common in infants. These are more common in infants. Okay, and if you're talking about cyst, clear, cyst is more common in older children and adolescents. So this is more common in older children and adolescents. Okay, now one by one we are going to discuss. First, branchial cyst. So here you can see this is branchial cyst, and it's the vestigial remnant of second branchial cleft. So this is a cyst known as branchial cyst. and this is vestigial remnant of second branchial cleft. Vestigial remnant of second branchial cleft. Okay, now see, what is the lining of this cyst? So this cyst is lined by squamous epithelium. So if you see the content of this cyst, it is thick, turbid, and it is full of cholesterol crystals. So what is the lining? It is lined by squamous epithelium. Okay, and the content is, it is having thick, turbid content which is full of cholesterol crystals. Full of cholesterol crystals. Okay, now see what is the location. So if you see, this is the sternocleidomastoid muscle, right? So this is upper 1/3, this is middle 1/3, and this is lower 1/3. So if you see the location, it is located at the junction of, can you see this junction? At the junction of upper 1/3 and middle 1/3. So this is middle 1/3, this is upper 1/3. Clear? So typically it is located at the junction of upper 1/3 and middle 1/3. What kind of swelling is this? It is soft fluctuant swelling, and here trans illumination is positive. So see the clinical features. Important point which is as related to branchial cyst is the location. So first, location. It is located at junction of upper 1/3 and middle 1/3. Upper 1/3 and middle 1/3 of sternocleidomastoid. Simple. It is soft, fluctuant, and here trans illumination is positive. So in these cases, trans illumination is positive. How we are going to make the diagnosis? We are going to make the diagnosis with the help of FNAC and ultrasound. And what is the treatment? We go for complete surgical excision. Clear? So it is diagnosed by FNAC and ultrasound. So these are used for the diagnosis. And how we are going to treat? We are going for complete excision of the cyst. So the treatment is complete excision of cyst. Now we are going to discuss branchial fistula. And what is branchial fistula? Branchial fistula is persistent second branchial cleft. It can be unilateral or bilateral. So branchial fistula is persistent. It is persistent second branchial cleft. Okay, it can be unilateral or bilateral. Now see, there is one condition known as branchial fistula and another condition is known as branchial sinus. What's the difference? So what's the difference between fistula and sinus? Fistula means communication between two epithelium lined surfaces, and sinus is blind having one external opening. Okay, so this is the difference. Now here you can notice that there is one external opening and it is in relation to lower 1/3 of sternocleidomastoid, and you can see it is located over the anterior border. So the external opening is in relation to lower 1/3 of sternocleidomastoid muscle and located anteriorly. If it is having internal opening, and this internal opening is generally in the tonsillar fossa, then it is known as branchial fistula, and if there is only external opening, then it is known as branchial sinus. Okay, generally this branchial fistula, so we are going to discuss branchial fistula. Branchial fistula, it is lined by ciliated columnar epithelium. So it is lined by ciliated columnar epithelium. Okay, and what kind of discharge is coming? So you can see here there is mucus discharge or mucopurulent discharge. So it is associated with mucus or mucopurulent discharge. So we discussed, this is the external opening. So here you can see this is the external opening. from which there is mucus discharge or mucopurulent discharge, and you see this is the internal opening, and internal opening is in relation to tonsillar fossa. What is the exact site? It is located at anterior aspect of, so internal opening is located at anterior aspect of posterior fascial pillar, anterior aspect of posterior fascial pillar, clear, behind tonsil. So this is the internal opening, and the external opening is in relation to lower 1/3 of sternocleidomastoid muscle along the anterior border. Now see the course of fistula. Here you can see the course. This fistula passes through carotid artery bifurcation. So if this is carotid artery bifurcation and fistula is going to pass like this, okay? So if this is carotid artery bifurcation and the course of fistula is through this carotid artery bifurcation, how we are going to treat this fistula or excise this fistula? So we have to give multiple incisions in step ladder pattern. So how we are going to excise this whole fistula? We have to give multiple incisions to excise the track of this fistula. So treatment is excision by transverse incisions, multiple transverse incisions, okay? So excision by multiple transverse incisions, and generally we give these transverse incisions in step ladder pattern, clear? So there is branchial cyst and branchial fistula, which are commonly asked in exam. Now we are going to discuss the branchial cleft remnants. First branchial cleft remnants, second branchial cleft remnants, and third branchial cleft remnants. So out of these, which one is most common type? Second branchial cleft remnants are most common and generally manifest as branchial fistula, which we just discussed. So one by one we are going to discuss. First we are going to discuss first branchial cleft remnants. First branchial cleft remnants. Okay. Now see what are the locations of first branchial cleft remnants. So it is located in front of here. It can be located in front of here, back of here, and it can be located in upper neck near mandible. Clear? So location front or back of here, it can be located, okay, and in upper neck near mandible, upper neck near mandible. So you can see the location, okay. Sometimes they ask you the course of fistula, right? Now you can see this is the external opening of the fistula and this is the internal opening. And where is the internal opening? This internal opening is in the external auditory canal. Clear? So external opening and internal opening is in the external auditory canal. Now see the course of fistula. So here you can see the fistula courses through parotid, sometimes through the facial nerve and sometimes deep to the facial nerve, and finally the internal opening is in the external auditory canal. Okay, so you can see the course of this fistula. Course. So this fistula courses through parotid, it courses through facial nerve, okay, sometimes it is going to pass deep to facial nerve, so courses deep to facial nerve. So finally it is going to open in external auditory canal. Clear? So where is the internal opening? The internal opening is located in external auditory canal. Clear? So these are the important points related to first branchial cleft remnants. Now see the second branchial cleft remnants, and we discussed this already. Second branchial cleft remnants. Okay, so overall second branchial cleft remnants, these are the most common type, right? So overall these are the most common type. External opening is located into lower 1/3 of the neck along anterior border of sternocleidomastoid muscle. The internal opening is located in tonsillar fossa. Where exactly? Behind the tonsil. And what kind of discharge is there? There is mucus or mucopurulent discharge. Now see the course. We discussed that the course of fistula is through the carotid artery bifurcation, and this course also passes behind posterior belly of digastric and stylohyoid. Clear? So posterior belly of digastric and stylohyoid muscle. Stylohyoid. Okay. So what is the course? Passes through carotid artery bifurcation. It passes behind posterior belly of digastric, stylohyoid, and finally it is going to open into tonsillar fossa. So this is the course, and we discussed how we are going to treat this condition. We have to give multiple transverse incisions in stepladder pattern, and we have to excise the fistula tract. Now see the third branchial cleft remnant. Third branchial cleft remnant. Generally, this third branchial cleft remnant, it does not have associated sinus or fistula. So if there is no sinus and fistula, what's the problem? In third branchial cleft remnant, over suprasternal notch and in this clavicular region, there is presence of firm mass, subcutaneous abscess or cartilaginous rest. So what are the important points? That it does not have associated sinus or fistula. So there is no sinus fistula. Okay. The abnormalities are seen in which regions? Here, suprasternal notch and in the clavicular region. So we are going to find abnormalities in suprasternal notch, over suprasternal notch, or in the clavicular region. Clear? And what are the remnants which are seen in these regions? We may find cartilaginous rest. There can be presence of firm mass or subcutaneous abscess. Subcutaneous abscess. Clear? So these are the important branchial cleft remnants. Now see this image. Here you can see this is the normal first rib, and this normal first rib is arising from first thoracic vertebra. Okay, but here you can see that there is a cervical rib which is arising from C7. So rib is arising from cervical vertebra, and that's why what's the name? It's known as cervical rib. So we are going to discuss in detail cervical rib. Okay, cervical rib. So it is arising from cervical vertebra. Which one? C7. So it arises from cervical rib, arises from cervical vertebra. Clear? So which cervical vertebra? It is arising from C7. You have to remember. And in majority of cases, it is more common on right side. Okay. Now see what are the various types of cervical rib. If it reaches up to the first normal rib, clear, it is known as complete cervical rib. And sometimes there is bulbous end, there is tapering end, and in certain conditions, it is just replaced by a fibrous cord. Clear? So what are the types of cervical rib? Types of cervical rib. It can be complete cervical rib when cervical rib reaches up to the first rib. Clear? It can have bulbous end, there is tapering end, and if it is replaced by a fibrous band, so it can be it is a fibrous band. So these are the types of cervical rib. Now see the location of this cervical rib. This is thoracic inlet. And what is the relation? You can see that over the first rib, there is a relation of what? Subclavian artery, subclavian vein and brachial plexus. So see the relation. So here you can see that there is neurovascular bundle in relation to the first rib, normal first rib. So there is subclavian artery, subclavian vein and brachial plexus. What is the problem? if there is cervical rib, so this is going to compromise this thoracic inlet, and if it is going to compromise the thoracic inlet in certain patients, it can lead to thoracic outlet syndrome. Now see, this is supraclavicular fossa. Okay, so sometimes there are local symptoms. You might find lump or tenderness in this supraclavicular fossa, and this cervical rib can compress the structures in the thoracic inlet, so there can be neurovascular symptoms. Imagine if there is compression of subclavian artery, so what will happen? Patient will be having pain, pallor, pulselessness, paralysis, paresthesia. And if there is compression of brachial plexus, most commonly involved root value is C81. So which nerve is most commonly involved? Ulnar. And these patients are going to complain what? Pain and paresthesia over inner aspect of forearm and hand. Clear? So what are the manifestations or symptoms in cervical rib? Clinical features. Okay, so patients can have local symptoms. Okay, so these local symptoms are seen in supraclavicular fossa. So patient can have lump, tenderness. So there is lump, there is tenderness. Where exactly? In the supraclavicular fossa. Clear? Second, there can be compression of subclavian artery. So compression of subclavian artery, and we discussed that whenever some artery is compressed, yes, it is characterized by 5P. Clear? If there is peripheral arterial occlusion, it is characterized by 5P. What is the most common P? There can be pain, pallor, paralysis, pulselessness, and paresthesia. Clear? And whenever there is involvement of brachial plexus, so what happens? It can compress. So there is compression of brachial plexus. What is the most commonly involved root value? We already discussed in thoracic outlet compression syndrome. So this is C8T1. So what is most commonly involved nerve? Ulnar. And that's why these patients complain of paresthesia and pain along the inner aspect of forearm and hand. Clear? So there is pain and paresthesia. So there is pain and paresthesia along the inner aspect of forearm and hand. Okay, inner aspect of forearm and hand. Clear? So these can be the clinical manifestations in patients of cervical rib. How we are going to make the diagnosis? So the diagnosis is made by X-ray neck. Okay, so we are going to make the diagnosis by X-ray neck and see the finding here. So you can see this patient is having bilateral cervical rib. So diagnosis can be made by X-ray neck. Now see the management. In cases of mild symptoms, so in mild cases we can just go for sling exercises. So how we are going to management? So in mild cases we can go for sling exercises. Okay, if severe symptoms are there, in those cases we have to exercise the scalenus anterior muscle, and this is known as scalenotomy. So if the patient is having severe symptoms, so in severe cases we go for scalenotomy. So here we perform the excision of scalenus anterior muscle. And if patient is having troublesome case, so in troublesome cases we should excise cervical rib. So here we perform cervical rib excision. Clear? So this is how we manage the patients of cervical rib. Now we are going to discuss the triangles of neck. there are two triangles. One is anterior triangle and one is posterior triangle. So see which one is anterior triangle. Here you can see this is the anterior triangle, clear, and this is the posterior triangle, clear. What are the boundaries of anterior triangle? Here you can see superiorly there is inferior border of mandible, and here you can see medially there is midline of neck. So this is midline of neck, and laterally you can see there is anterior border of sternocleidomastoid. Okay, so what are the boundaries of anterior triangle? Superiorly there is inferior border of mandible, medially there is midline, and laterally there is anterior border of sternocleidomastoid. Now see what are the boundaries of this posterior triangle of neck. So this is the posterior triangle. So here you can see that anteriorly there is posterior border of sternocleidomastoid. Posteriorly this is the trapezius muscle. So posteriorly there is anterior border of this trapezius. Inferiorly it's the middle 1/3 of clavicle. So what are the boundaries? Anteriorly posterior border of sternocleidomastoid, posteriorly anterior border of trapezius muscle, and inferiorly it's the middle 1/3 of clavicle. Now see, this anterior triangle is further divided into four triangles, right? What are those four triangles? If you see, this is one triangle and this is known as submental triangle. Now see, what's the name of this triangle? This is known as submandibular. Third is carotid triangle. So this is carotid triangle, and the fourth is muscular triangle. So anterior triangle is further divided into submental, submandibular, carotid and muscular triangle. What are the boundaries of these triangle? Have a look. So first see, this is the submental triangle. So here you can see inferiorly there is hyoid bone. Inferiorly there is hyoid bone. Here you can see medially there is midline. It's the midline. And if you see laterally, this is anterior belly of digastric. So laterally there is anterior belly of digastric. So what's the name of this triangle? This is submental triangle. Okay, this is submental triangle. Now see, the another is submandibular. So you can see this one is submandibular. So in this case you can see superiorly there is mandible, anteriorly you can see there is anterior belly of digastric, and here you can see this is the posterior belly of digastric. Okay, so what are the boundaries of this triangle? This is submandibular triangle. Clear? So superiorly there is mandible. So superiorly there is inferior border of mandible. You can see anteriorly there is anterior belly of digastric, and posteriorly there is posterior belly of digastric. So anteriorly there is anterior belly of digastric, and posteriorly there is posterior belly of digastric. Clear? So this is submandibular triangle. The third triangle is this one, and this is known as carotid triangle. So what are the boundaries of carotid triangle? Here you can see superiorly there is posterior belly of digastric. Inferiorly you can see there is superior belly of omohyoid, and laterally this is lateral border. So laterally there is medial border of sternocleidomastoid. Okay, so see the boundaries. This is carotid triangle, carotid triangle. And what are the boundaries of carotid triangle? You can see superiorly there is posterior belly of digastric, posterior belly of digastric. Clear? Inferiorly there is superior belly of omohyoid, that's omohyoid, and laterally there is medial border, laterally there is medial border of sternocleidomastoid muscle. Clear? So this is carotid triangle, and these are the boundaries. Now the fourth triangle is this muscular triangle. Can you see? Okay, so here if you see the boundaries of this muscular triangle, you can see that superiorly there is hyoid bone. Which one? Hyoid bone. And if you see superolaterally, here you can see superolaterally there is superior belly of omohyoid, and if you see inferolaterally there is inferior portion of sternocleidomastoid muscle. And what's medially, here you can see it's the midline. So what's the name of this triangle? This is known as muscular triangle. So see, what are the boundaries of this muscular triangle? This is muscular triangle. Okay, so superiorly there is hyoid bone, superolaterally there is superior belly of omohyoid, there is superior belly of omohyoid. Clear? Inferolaterally there is inferior portion of sternocleidomastoid muscle, inferior portion, and medially is the midline. It's the midline. Clear? So anterior triangle is further divided into these four triangles: submental, submandibular, carotid, and muscular triangle. Now see what are the various lymph node levels in the neck. So see this one, this is submental 1A, and this is submandibular 1B. So 1A submental, 1B submandibular. Along internal jugular vein, it is further divided into upper jugular, middle jugular, lower jugular. So level 2 is upper jugular, level 3 is middle jugular, and level 4 is lower jugular. 5 is posterior triangular. It is located in posterior triangle, so it is posterior triangular. 6 is central or anterior compartmental. And what is 7? 7 is superior mediastinal. So these are the lymph node levels. So we are going to discuss one by one. Here you can see this is 1A. So this is submental. 1A is submental. You can see 1B. This is submandibular. Then along internal jugular vein there is 2, 3, 4. 2 is upper jugular. So this 2 is upper jugular. This 3 is middle jugular, and this 4 is lower jugular. Okay. Now here you can see there is a nerve. Can you see this nerve? Yes. So this is spinal accessory nerve. Okay. So level 2 is further divided into 2A and 2B. The lymph nodes which are anterior to spinal accessory nerve, that is 2A. So can you see here? This is anterior to spinal accessory nerve. And this level 2B, this is posterior to spinal accessory nerve. So what is 2A? This is anterior to spinal accessory nerve, and 2B, it is posterior to spinal accessory nerve. So there is middle jugular, that is level 3, and 4 is lower jugular. You can see 5 is posterior triangular. Okay, and 5 is further divided into 5A and 5B. In relation to inferior border of arch of cricoid cartilage. Can you see? Here is the cricoid cartilage. So this is the inferior border of arch of cricoid cartilage. So if the lymph node is superior to inferior border of arch of cricoid cartilage, this is 5A, and if it is inferior, it is 5B. So 5 is further divided into 5A and 5B. So this is level 6, and level 6 is central. It is also known as central or anterior compartmental. So this is central or anterior compartmental. So what is level 7? Level 7 is superior mediastinal. So these are the lymph node levels in the neck. There is one famous question which was asked in NEET 2 to 3 times, that if a patient is having enlarged supraclavicular lymph node, can you see? This lymph node is located here. So this is enlarged supraclavicular lymph node. Yes, it is included in which level? Enlarged supraclavicular lymph node. It's on left side, that's known as left supraclavicular lymph node, is known as Virchow's node, and it is included in which group? So Virchow's node, it is included in level 4. Clear? In certain books it's written that it is included in level 5, so that's wrong. It is included in level 4. left supraclavicular lymph node is known as Virchow's node, included in level 4. Next, there is precricoid or prelaryngeal lymph node. So see the location. If the lymph node is located here, precricoid or prelaryngeal, this is also known as Delphian nodes. Okay, so Delphian nodes are included in which group? Level 6. Okay, very important point. So this is Delphian. Delphian is precricoid or prelaryngeal nodes, and Delphian lymph nodes are included in level 6. So level 4, level 6. Now see another important point related to carcinoma thyroid. In carcinoma thyroid, what is the most commonly involved group of lymph node? And that is central or anterior compartmental. Which level? Level 6. So in carcinoma thyroid, there is involvement of central or anterior compartmental lymph node, level 6. That's why we discussed that in papillary carcinoma thyroid, we have to go for removal of enlarged central group of lymph nodes. And we discussed that in medullary carcinoma thyroid, we go for routine central lymph node dissection. Clear? So these are important points related to lymph nodes of neck. Now we are going to discuss the lymph node dissection. There are two types of dissections which are frequently asked. One is radical neck dissection and second is modified radical neck dissection. Now see what we are going to remove in radical neck dissection. So in radical neck dissection, you can see we are going to remove level 1 to level 5 lymph node. Apart from this, we are going to remove what? Spinal accessory nerve. Can you see spinal accessory nerve? There is internal jugular vein and what else? Sternocleidomastoid muscle. So apart from removal of level 1 to level 5 lymph nodes, we are removing three structures: spinal accessory nerve, internal jugular vein, sternocleidomastoid muscle. If we remove level 1 to level 5 lymph nodes with preservation of at least one of the following: spinal accessory nerve, internal jugular vein, sternocleidomastoid muscle, then it is modified radical neck dissection. Clear? Usually we preserve all the three. So see what are the differences. First, radical neck dissection. Okay, so what is removed in radical neck dissection? We remove level 1 to level 5 lymph nodes plus three structures: spinal accessory nerve, internal jugular vein and sternocleidomastoid muscle. We remove all these three. So there is removal of level 1 to level 5 lymph node plus spinal accessory nerve, internal jugular vein, sternocleidomastoid muscle. And what is modified radical neck dissection? So in modified radical neck dissection, we remove level 1 to level 5 lymph node plus preservation of at least one of the following. And what? Spinal accessory nerve, internal jugular vein and sternocleidomastoid. Usually we preserve all the three. Now see, if we are going to preserve only spinal accessory nerve, this is type 1 MRND. If we preserve spinal accessory nerve and internal jugular vein, this is type 2 MRND. And if we preserve all the three, this is known as type 3 MRND. And this type 3 MRND is also known as functional neck dissection. What's the other name? It is also known as functional neck dissection. Clear? So easy to understand. Nowadays they are asking types also. What is type 1 MRND? What is type 2 MRND? What is type 3 MRND? So it's very easy to remember. Mnemonic is CISP. It's not GISP, it is CISP. So if we are going to preserve only spinal accessory nerve, this is type 1. And if we are going to preserve only these two, spinal accessory nerve and internal jugular vein, it is type 2. And if we are going to preserve all the three, it is type 3. S is spinal accessory nerve and SM is muscle. Which one? Sternocleidomastoid. So that there is no confusion, I made S spinal accessory nerve and SM sternocleidomastoid muscle. So these are the types. Then there are types of selective neck dissections also, which are frequently asked in exam. Now see the types of selective neck dissection. Can you see what's the name of this muscle? This is superior belly of omohyoid. So this is superior belly of omohyoid. So there is one dissection known as supraomohyoid neck dissection. If we are going to perform the supraomohyoid neck dissection, can you see which lymph nodes are removed in supraomohyoid neck dissection? You can see we are going to remove level 1, level 2, level 3. This is supraomohyoid. Then if we are going to perform extended supraomohyoid, which group is included? Level 4. So in supraomohyoid neck dissection, level 1 to level 3 is removed, and in extended supraomohyoid neck dissection, level 1 to level 4 is removed. Clear? So this is supraomohyoid. Neck dissection, and it is going to remove lymph node level 1 to 3. So lymph nodes from level 1 to 3 is removed, and here you can see this one is extended supraomohyoid. Clear? Neck dissection, and in this case we are going to remove level 1 to level 4. So we are going to remove level 1 to level 4 lymph node. Now see, if we go for lateral neck dissection, so in lateral neck dissection we are going to remove what? Level 2, 3, 4. So level 2, 3, 4 is removed in lateral neck dissection. And if we go for posterolateral neck dissection, so in posterolateral neck dissection we are going to remove level 5 also. Apart from level 5, suboccipital and retroauricular lymph node. Clear? So see, this is lateral neck dissection. So this is lateral neck dissection, and in lateral neck dissection we are removing level 2 to level 4 lymph node. Okay, and what about posterolateral? So this is posterolateral. This is posterolateral neck dissection, and in this case level 2 to 5 plus we remove level 2 to 5 lymph node plus suboccipital and retroauricular. So we remove suboccipital lymph node plus retroauricular. And the easiest is central compartment neck dissection. So if we go for central compartment neck dissection, which level removed? So in central compartment neck dissection we are going to remove level 6. So this is central compartment neck dissection. Okay, and in central compartment neck dissection we are removing level 6. Clear? So it is easy to understand. You should remember, because nowadays, especially names, they are asking the types of neck dissection. Now see what are the complications of neck dissection. So there are intraoperative complications and there are postoperative complications. Intraoperatively, we are prone to injure nerves, vessels, thoracic duct. Clear? So see what are the complications of neck dissection. Neck dissection complication. Okay, first intraoperative and second is post-operative complications. So intraoperative and post-operative. So the intraoperative complications are injury to nerves and vessels. So which nerves and vessels? There can be injury to nerves and vessels. So it can lead to injury of marginal mandibular nerve, spinal accessory nerve. There can be injury of thoracic duct, injury of cervical plexus and brachial plexus. So these are the intraoperative complications. Now see the post-operative complications. Post-operatively, there can be hemorrhage. There can be lymph leak because of injury to lymphatics. So lymph leak. And there is a complication which is having highest mortality rate. How much? 60%, and that is carotid blowout. What is this carotid blowout? It is because of rupture of carotid artery or one of its branches. So it is carotid blowout. It is having highest mortality. Okay, how much is the mortality? 60%, and it's because of rupture of carotid or one of its branches. There can be shoulder syndrome also. So this shoulder syndrome, obviously it is because of injury to which nerve? Spinal accessory nerve. And what happens in shoulder syndrome? Here the patient is not able to abduct the shoulder beyond 90 degree. Clear? What is the problem? If you are going to examine, patient complains of pain and you can see that there is deformity at shoulder girdle. So these are the complications of neck dissection, and this is all about neck.